right. Hello, everybody. Welcome to the next episode of the Primetime Mindset podcast. And this podcast is where we dive into the habits, mindset, behind the scenes stories that fuel success in fitness, business, and life. I'm your host, Jarrett, along with my co-host, Amena Tareen. And before we jump in, I want to just make sure to share what the show is all about. The Primetime Mindset isn't just for athletes, it's for anyone showing up every day to be better than they were yesterday. It's about preparation, pressure, progress, and how we push through the moments that matter the most. Today's guest embodies all of those elements. Dr. Sun is an outdoorsman, someone that his patients describe as attentive, thorough, and supportive. So, Dr. Sun, welcome to the podcast.
Yeah, thanks so much for having me. This is a pleasure.
Not a problem, not a problem. So, just to kind of launch into that outdoorsman part a little bit, I saw that you like to travel, alpine hiking, reading, shooting sports. So, talk a little bit about your hobbies, and then maybe how those hobbies, if at all, influence your approach to medicine and how you talk to and get your guests to feel comfortable.
Yeah, no, for sure. I think ever since I was a kid, I've always kind of been into just being outside and doing stuff. Got into like just sort of long distance hiking, probably because I grew up in Maryland and we're like much on the Appalachian Trail. So did a lot of sections of that. Haven't done the whole thing, of course, in one go, but just a lot of different sections up and down. Lived in Maryland for a while, Connecticut, Boston, so got to hit a lot of that. Done some international stuff. One of those things I just started liking to do. I would just take off like 2 weeks a year and join these random groups where they would just like you join as a solo person and then you just meet like 15 other people and you just do some hikes. So I did like Mount
Wow.
Kilimanjaro, or I did like the Tour de Mont Blanc, which is like an 11-day hike in the Alps. You just meet like cool people. I think, traveling and like meeting all sorts of different people kind of gives you an appreciation for how different but also similar everyone really is.
Yeah.
And certainly in my world of medicine, one of the unifying themes, especially with men, is that even though a lot of these guys like that I met, a lot of them are guys, they're young, they're healthy, they think they're healthy, but they don't actually take very good care of themselves because they haven't been to a doctor in like 10 or 15 years, because they're just assuming everything is fine. And lo and behold, a lot of times not everything is fine. And so, using that sort of environment, but also as a leverage point to talk about like men's health in general, that's what my subspecialty field is. I just treat men and do men's health stuff. And I think it's a great way to reach men in these years between when they leave their pediatrician at age 18 to when they like finally have to go see a doctor at like age 60. There's this huge gap in there, and be able to get those guys to like enter the medical system and at least check in on a few things, take care of themselves, I think does a great service to their health and their lifespan overall.
Very nice, very nice. So just to clarify, you travel somewhere else, meet up with a random group of people, not random, but a group of people that are going to
Random.
hike.
Yeah.
But here's, see, this is how my mind works. How do I know that my skill set is at any level to what they're at, and they don't want to go hiking for 30 miles straight up a mountain? And I'm like, yeah, I can't do that. So I'm assuming
Yeah.
there's some conversation about
There's
that.
like there's like these things are usually organized. So you're like signing up for like a trip. There's like a guide, and then there's like 12 slots, and like some people come as like groups of friends. Some people just come solo. I went on the Kilimanjaro trip solo. Met a bunch of people and then like stayed in touch with them, and like several years later, four of us together that were friends from that trip signed up for like a different group trip to do the Tour de Mont Blanc thing with another like 8 other random people. And so like there's some assessment of like what skill level you're at and that kind of thing.
Nice. Okay.
Yeah.
All right. That's pretty awesome. So transitioning to you had talked about helping guys feel, helping them understand that, hey, during that gap, things are happening to your body, that 18 to 60 gap, things are probably happening to your body, and as we say, gradually, so you don't really see it. How do you get them to understand, one, to feel comfortable enough to have the conversation, and then to understand you need to take a step somewhere. If you start seeing changes where you can't do things like you can't go on these hikes like you used to. How do you get them comfortable to come in and or just go see somebody and
Yeah.
have very, very sensitive conversations?
Definitely initially that's the biggest challenge is just getting them in the door. And so once they're in the door, like I'm pretty chill with my patients. I just make it very comfortable and realize that like they might be feeling awkward, but like within 10 seconds of meeting me, I think I can diffuse most awkwardness because there's pretty much nothing that anybody will tell me that I haven't heard before. The
Yeah.
key is how to get them in the door. And I'm very practical when it comes to that. Growing up and like how all this like different stuff with smoking and drinking and all this, but like you realize that like if you tell men, specifically men, women are much better at this, but if you just tell men like don't do this, don't do that because you'll get a heart attack, they're like nah, don't really care, right? Or they don't do anything about it until they're like literally starting to feel the chest pain. And so my subspecialty of urology, specifically men's health urology, which focuses on two primary aspects, which is sexual health and infertility. To me, these are the two things in an age group of, let's say, 18 to 50 that either will force men to go to the doctor, like infertility, they're not able to have start a family and have a child, or their sexual health. To put it bluntly, there's one thing that most men care enough about to actually do something about, and that's when their junk doesn't work anymore. So not a
Yeah.
heart
Yeah.
attack, not high blood pressure, it's not cholesterol. They couldn't care less about those things. It's when their penis isn't working. And the thing is that the most common causes of erectile dysfunction are high blood pressure, high cholesterol, low testosterone, diabetes, like all those other things. And so you're ultimately still trying to get those guys to address those fundamental underlying issues. But the way to do
Yeah.
it is to get them caring about either their low testosterone or their erectile dysfunction.
Very, very, very true. And I don't know if you had a follow up to that.
Yeah, I think that's really interesting. It's a great point that you mentioned. And I find that I see a lot of patients at the clinic, and that is often what I hear from most people, that they've never been to a doctor. They can't remember the last time they went, but they'll walk into our clinic because things don't work right. And,
Yeah.
and my question to you, which I think you pretty much answered, but what are the common urological conditions that you see in men that often get ignored and people should pay more attention to?
Yeah, totally. I fully agree. I think in many ways we serve as the front door entrance for a lot of these guys. Traditionally that's the primary care doctor's role, but these men, they're just hesitant to go see a primary care doctor. But for our type of medicine, this is something that they're actually interested enough to go see. For us, I would say number one complaint in my clinic is probably low testosterone. There's a lot of advertising about that. Everybody kind of knows about that. So I have never met a man when asked, hey, do you want to check your testosterone, to say, no, don't really want to know what that is. Everybody wants to know. Number
Yeah.
two, probably erectile dysfunction. Happens to the best of us, happens to all of us at some point. It is starting to happen to people earlier. And I think that is unfortunately just a reflection of the fact that the overall health state of the country is worse, right? Obesity, diabetes, high cholesterol. I'm like, if those things are going to clog up your blood vessels in your heart someday, they're definitely going to do it in the penis, and they do it first. So we refer to the penis as the check engine light of the body because it's
Wow.
usually the first sign that something deeper is going on. And generally, if you're healthy, your sperm will be healthy, your sexual function will be healthy. And if those things aren't good, it usually reflects something else going on. And then fertility would be the third one. A lot of times, I think historically, unfortunately, women have borne the entire burden of like infertility. And it's very unfortunate when I see couples come in, they've been trying for like 3 years. She's done all this workup and the guy's never had like a simple semen analysis test. I'm like, come on, it's super easy to do. You do it every day anyway. So
Yeah.
just get it checked, and suddenly you can diagnose something. And like I said, all of these things are usually harbingers of deeper seated like metabolic problems that we aim to treat.
So, can you explain a little further in simple words as to when a man is struggling with ED? What's really going on medically, and how can are there simple solutions out there for that, or What is your take on
Yeah,
that?
absolutely. So when I see the guys with ED, I tell them there's 4 things that you need to make a penis work, right? You need hormone function, you need blood flow or vascular function, you need neurologic function, and you need psychologically, to be of sound mind. Now, obviously, sometimes it's all the psychological part. This, unfortunately, is also becoming more common due to things like the extremely wide availability of porn, like starting at a young age, But let's be honest, every man on the planet, there's a psychological piece in terms of performance anxiety and that kind of thing. But we'll focus on the 3 biological pieces. Blood flow, that, unhealthy blood vessels lead to poor erections. So high blood pressure, cholesterol, things like that. The blood vessels in the penis are much smaller than the blood vessels in the heart. And so the first sign of endothelial vascular dysfunction is not necessarily a heart attack. It's usually erectile dysfunction, because you'll notice that first. Nerve function is also necessary, especially for natural sort of elicited, libido-driven erections. The 2 biggest things that impact nerve function are diabetes and having your nerves in the pelvis, traumatized, say through prostate cancer surgery, because that's a very common surgery that we do. The third thing is testosterone. Testosterone is the critical sort of male, sexual hormone, although it's also a critical female sexual hormone, just in a much lower, percentage. Super important. If you have 0 testosterone, you're going to have no sex drive. You're going to have no erectile function. But the opposite is not entirely true, right? We get many men that come in asking for low T treatment purely for the purpose of fixing their erectile dysfunction. And I tell them it's a necessary but not independently sufficient aspect, right? You need some testosterone. You don't want to have a testosterone of 0, but making your testosterone 2,000 is not going to make your erections better than if your testosterone was 1,000. You've already checked that box. Now we have to work on the other boxes, the vascular, the neurologic, the psychological pieces of it. But regardless, it is still a very important piece.
Why do you feel that more and more younger men are struggling with ED? What's causing that?
Lots of things. We did see a big spike in ED after the Delta wave of COVID. If you remember, that particular COVID variant was much more vascular. They were getting like blood clots and strokes and all this kind of stuff. And so right after that, there were some interesting papers published about this like spike in ED in young men, because I think that the blood vessels in the penis were also being affected. I do think that much of this issue is probably one we're hearing about it more. People talk about it more. It used to be much more hidden, and we didn't have like online telehealth companies like broadcasting like ED treatments all the time, right? But direct to consumer availability of Viagra and Cialis, which is overall a great thing, definitely has increased the knowledge of this. But then I do think nefariously there is a downside, which is that back in my day, which wasn't that long ago, like it was difficult to get access to pornography, right? You had to like sneak around and get a magazine or whatever it was. Now it's available at everyone's phone all day, every day for free, and I definitely think that is having an effect on the younger men. And then they get so used to that, right? That then when they finally start to have a relationship, it's obviously not the same. And so there's this big psychological piece that starts to come with it as well. There is probably some element with, relationship in terms of childhood obesity and the fact that like even kids, unfortunately, are becoming obese, which is not good for their, vascular stuff. But I think that it's a combination of those physical factors and the psychological factors.
It's really interesting.
Yeah.
Very interesting. Very interesting. So you talked about getting guys in, getting them comfortable, going through the 4 elements that they need to think about when they, when it comes to erectile dysfunction and all of that. How do you handle the guy that has sat through all of that? He comes to your clinic. He came in talking about his issues, came in explaining, I have all these things going on, and you've explained this to him, and he still is kind of like, I think I can figure this out. I think I can make this work. How do you kind of coach them, or let's just use the word coach them on this is your stop. Like you've made your final stop. This is where we fix it. You're not going to fix it out there. How do you have that conversation?
Yeah, no, it's a good question. I think my initial evaluation for most people roughly ends up being the same, which is some talking, and then I usually always check their labs, check their testosterone levels and these kinds of things. I also check their thyroids and like all these other, aspects that especially if they have not had a primary care doctor since their pediatrician. Like I'll check their lipids, their cholesterol, all of this business. Many times they're coming in with erectile dysfunction, My first treatment for almost all men of every age group is low dose 5 milligram daily Cialis, or tadalafil, not the name brand. I think giving somebody an on-demand medication only, like here, take this sildenafil Viagra when you want to have sex, is a great band-aid, but doesn't address anything deeper down, doesn't get them to address the high blood pressure or whatever they have, and it actually creates a psychological dependency on that medication. Whereas taking a low dose tadalafil every day, one, long-term seems to improve overall endothelial function with more nitric oxide and that kind of thing. And two, now I'm not wanting you to think about this as a, ED medication. This is a penis vascular health medication that you just take every day or every night. You're not even thinking about it. You're not tying the taking of this medication to the sexual encounter. It's just something that you take like a vitamin. And overall, that ends up being a lot better. And we've had some studies that show that if you do this for 3 months in, say, a younger man with erectile dysfunction, even after he stops the medication, he'll actually be a lot better than he started out with. Then I usually have them come back, and if we talk about their weight and if they're clearly obese, I'll mention things like, if willpower alone was enough, like we wouldn't be in the situation that we're in. So, there's a lot of wonderful medications now that you can use. It's not a sign of weakness to reach for a GLP-1 if that's the best treatment for you. Sometimes, they want to give it a go. I'm like, all right, well, we got the labs, I'll see you back in like 2 or 3 months. Let's see if we can lose 5 pounds. And if they come back 3 months later and they haven't lost a pound, then I'm like, okay, well, clearly we need to do something a little bit more. And just on that note, as a bridge, so many men now are on these GLP-1 agonists for weight loss. But one of the things that I think we don't do well enough of is check their testosterone at the same time, right? All obese men basically have low T. And then you put them on something that makes them significantly reduce their calorie intake, but then they still have low T. So they're not getting any like muscle anabolic activity. So they end up shedding all this muscle and becoming sarcopenic. And so I have a big sort of combination thing with some bariatric surgeons and some endocrinologists where, these weight loss patients will come to me and I'll just give them testosterone purely for the purpose of helping to improve their metabolism, help them lose weight better, help them retain muscle, right? You got to like lift some weights, but then you got to eat protein, take the testosterone, then you're really doing much better than if you're just taking GLP-1s and like starving yourself, right?
Yeah, we've had some similar conversations with folks, and I try not to and I'm not, obviously I'm not a medical professional, but when I'm talking to them in the lobby, I try to have a very gentle conversation about, this is kind of what's going to happen on the GLP-1. Your appetite's going to be suppressed. So you're not you got to make sure you try to get in some protein and some workouts. It's just not going to do everything by itself. So it's very interesting.
Yeah. And in that sense, there's a variety of different testosterones that you can use, of course, classically injections. And then we have these like new oral testosterones. The thing that I like about it is that because it is less suppressive to the endogenous system, like the theoretical goal for the morbidly obese guy is to lose the weight such that his testosterone is now good again without the need for anything. To help him get there, you have to give him some testosterone to ramp up his metabolism to help him lose the fat and build the muscle. But if you give him something that's like completely suppressive, as long as you do that for a relatively limited time, they will probably recover their T levels later. I like the use of the shorter acting oral testosterone in this space because it gives them the metabolic boost of the testosterone, but in a controlled time frame while not completely suppressing their endogenous function, because my ultimate goal for him is to lose the weight so that his endogenous function ramps up later with the final state of not having to take anything and him just being much healthier. Now, I wish I could say that happened all the time, but that is at least the goal.
So if someone's diagnosed with low T, can diet and exercise alone help improve it?
Absolutely. It's just that it's easier said than done, right? Purely speaking, like weight loss causing increased testosterone is well validated. If you lose 10 to 15% of your body mass, average T level goes up by like 180 to 230 points, which is a lot, right? And so, yes, most people do not have low T because of like primary testicular failure or some kind of genetic problem, right? They have it because of lifestyle, sleep or lack thereof, stress, obesity, lack of activity, like all these kinds of things. And so if you correct those things, you can probably fix a lot of people. It's just that it's not that easy to correct those things. And when they have low T, it creates that vicious cycle where now they have no energy or desire to go do anything. And so sometimes it's like, we know that the end goal here is healthy living, healthy life, it's healthy body. But in order to get you there, I got to give you a little help. And the help comes in the form of pharmaceutical testosterone, right?
Yeah, that was kind of one of my questions, and I think you between what Amina said and what you were mentioning there was, what is the thing you tell people, hey, if you want to improve your overall sexual health, well-being, without any pharmaceutical, you got to do this. But it's kind of to me, I always tell it, it's a chicken and egg thing, right? You've been sitting on the couch, so you don't have the energy to go do the things I'm about to tell you to go do.
Right.
So
Right.
I got to give you something to give you the energy to go do it.
Exactly.
So that's very, very, very interesting. I'm glad a medical professional just said, similar things
Yeah, no.
I've been thinking and feeling, right?
Yeah.
So, okay.
So, I mean, we have a
Do you have
lot
a
of
follow-up to that?
patients.
Go ahead.
Sorry, Jarrett. We have a lot
No,
of
go ahead.
patients that come in and they've heard about tea. A lot of people are talking about it now. Their friends are talking about it, but there's still a lot of myths around it. Can you describe us some of the myths that are kind of, surrounded by TRT and what those are and whether they're true or not?
Sure. Yeah. No, I love it. Absolutely. I totally agree. There are still a ton of myths. I think for a long time, and this is why testosterone is still schedule regulated by the DEA. Testosterone has existed in this realm of, contraband steroids, like bodybuilding, and like therefore it's bad. Whereas we're trying to sort of shift the conversation to think of the idea of testosterone. Testosterone is critical health metabolic hormone, right? Like everybody needs it. Men need it, women need it. And if you don't have it, everything else works less well. Diabetes becomes less well controlled. Weight is harder to keep off. Lots of things come as a result of having low testosterone. They also can cause low testosterone. Probably some of the biggest myths I would say is testosterone causes prostate cancer, right? This has been probably the biggest myth to dispel. And so I'll go on a few minutes about that. The original papers that showed the relationship between testosterone and prostate cancer only showed that relationship from a negative aspect, meaning patient has prostate cancer, remove testosterone, prostate cancer dies. Then we just assumed that the opposite was true, that we give you testosterone and causes prostate cancer. It was never actually shown. And even in that original paper from like the 30s, it was one patient, right? So the entire field of testosterone and PSA and prostate cancer is based on this one report by this one patient, but it's like the most famous paper in urology. If, however, you logically think about it, if high testosterone caused prostate cancer, then why aren't a bunch of super athletic 20 and 30-year-olds getting prostate cancer? Why is it like 60 to 70-year-old guys with low testosterone? And why is it that you can have really low T and still get prostate cancer? It's because although the prostate cells require testosterone, more testosterone above a certain threshold does not further increase it, right? We believe that, and this is work done by Abe Morgenthaler, who's been revolutionary in our space. We believe that the threshold of saturation of the prostate with testosterone is somewhere around 250, maybe 300. So if you take a testosterone of 100 and make it 500, your PSA will go up and you'll do something to the prostate. But if you make it 400 and make it 800, it doesn't change anything. It doesn't change the PSA because the prostate is already saturated with all the testosterone that it needs. And overall, the metabolic consequences of having low T are much worse than the potential risk of doing something with prostate cancer. We don't just go and castrate healthy men to prevent their prostate cancer, right? So ultimately, I think that the final conclusion is it's like being way too high is probably not good. Being low is definitely not good. We in fact show that men with low T, not only do they get prostate cancer, when they get it, it's usually more aggressive because that prostate cancer has essentially learned how to grow in a low T environment, which means it's not as sensitive to the treatment, which is removing the testosterone. So it actually becomes more aggressive than regular old prostate cancer. Biggest myth, number one, but it's still important to check the PSA. I work with a lot of low T centers locally, actually, and they send me patients when they have elevated testosterone, elevated PSA, because we need to make sure that things are okay down there, right? Myth number two is sort of the opposite, I would say, which is not a good thing, which is a lot of people don't realize that in general, taking testosterone decreases a man's fertility. Like, this is just the reality, right? And I see, unfortunately, too many men are not told this. When you make more of your own internal testosterone, it's helpful for fertility. When you take testosterone from the outside, it decreases your fertility. Now, that's not something that's permanent. Usually you can reverse it, but it is something important to know. And so, we're always wanting to have that conversation whenever we're talking about starting testosterone on a guy who is wanting to have more children. If he's like 65 and totally done having kids, not that every 65-year-old is totally done having kids, but we don't really care as much. But in the younger guys, like, that is an important thing to know. There are trying to think. I guess those would be probably the biggest two things that we get the questions most of, which is this testosterone that I'm taking boosting my testosterone? I'm like, it's not necessarily boosting your testosterone, it's replacing your testosterone. And don't worry, it's not going to give you prostate cancer.
Yeah.
You bring up a really
Very true.
interesting point. These are things that are discussed in our clinic and often concerns for most patients, right? Those two very things. But at the same time, I know, like you mentioned, testosterone doesn't create or cause prostate cancer. But what about heart issues? Because the blood does get thicker.
Yes, you're right.
How is that related?
Yeah, that is actually, I can't believe I didn't mention that. In 2013, a series of papers came out, actually here in Dallas from UT Southwestern, and created this unfortunately big artificial scare about testosterone and heart disease. These papers supposedly showed that taking testosterone caused more heart attacks. Now, the problem is if you actually look at the data, there are lots of problems with that data set. First of all, it was like 11% women. Secondly, it was through statistical manipulation that conclusion was reached. And if you really look at the data, the men who took testosterone actually had less heart attacks. But of course, like all scary news, it made the news nationally, and people got really spooked by it. So at that time, the FDA commissioned a clinical trial called the Traverse study, the biggest study ever on testosterone. 5,200 patients randomized to nothing or testosterone. And basically what they showed, and this was published maybe 2 years ago, is that testosterone does not cause more heart disease. It does not cause more heart attacks. It doesn't do anything of the sort. And in fact, the preponderance weight of the data on meta-analysis shows that having low testosterone actually increases your risk of major adverse cardiac events, right? There's a great meta-analysis from Australia looking at all the data, and it's like below about 200 is when your risk of heart disease actually goes up. And so I have started telling my patients, like, if your T is 285, I'm like, look, that's low. You may not feel great. Whether you start testosterone, it's kind of up to you. You could, you don't have to. If it's like 700, I'm like, look, bro, you probably don't need it. But if it's like 115 and the guy's like, well, I feel okay, I'm like, yes, maybe you don't know how you should feel, but there is actually medical danger for you right now being so low on testosterone, to your heart, to your bones, to a lot of things. We should raise your testosterone to like a more normal number purely for the medical aspects, even though you're like not necessarily feeling it, and you probably will still feel better. So really, you don't want to be like really low, like below 200, something like that. But it definitely does not cause heart disease. Now, it does cause polycythemia or secondary erythrocytosis, which means you make more red blood cells. And theoretically, having more red blood cells makes your blood thicker. And theoretically, that increases your risk of, blood clots and stuff. Now, that's never really been conclusively proven. So it's more of like a correlative thought. And just out of an abundance of caution, we like to avoid really high red blood cell counts, like, it is definitely something that we manage, and probably the most common thing that we have to kind of watch for, because, we have admittedly artificially created some numbers to try and stay below, right? So hematocrit 52, 54, depending on who you read. Certain things increase your likelihood for this. The biggest one is being obese and sleep apnea. Why does sleep apnea increase this? If you think about it, a sleep apneic patient is not breathing at night. His body thinks his oxygen level is low. The body's way of getting more oxygen is to make more red blood cells. And so that's why you make more red blood cells. If you look at people that like live in Tibet, their hematocrits are like 60 at baseline, but they're used to it, right? And so we definitely see this more often in like high altitude places. So in the US, in Denver, they have really high rates of polycythemia, whereas like here in Texas, it's not so bad, but it's still pretty common. That doesn't cause heart attacks per se. That's never been shown. We just have this like kind of theoretical fear that it might make your blood too thick and you might get a blood clot. So we just try to manage that and keep it lower. Conventionally, the injectable testosterones have a polycythemia rate of about 30 to 40%. Some of the shorter acting ones, topicals and oral testosterone from decanoate, has a polycythemia rate of about 3%. And so in a patient who has this problem significantly, you can either keep them on the injections and have them go donate blood like all the time. Sometimes they donate blood too much and become iron deficient, or you can convert them possibly to a form of testosterone that does not cause this issue quite as much. And you can mitigate their risk factor. For example, of sleep apnea, you can get them a CPAP mask.
Wow, that's great information. And it always, I'm glad you mentioned that about the heart attacks, because it always seemed to be a disconnect for me, you know, because we're saying that adding testosterone or getting your levels corrected increases your, or you know, improves your cardiovascular disease issues, or you know, potential. But at the same time, we're saying, hey, it can cause heart attacks. So it always seemed to fight
A
against each
lot
other
of
in my
things, like,
mind.
I mean, testosterone is testosterone, right? It's a hormone that you already make. And so if it was true that higher testosterone levels cause more heart attacks, then similar to the prostate cancer, you should have all these like young, healthy, athletic, you know, 20 and 30, 40-year-olds getting heart attacks. But that's not who gets heart
Yeah.
attacks, you know? And so it
Right.
never really made sense. We don't go out and be like, oh, your T is 700. Ooh, too high. You might get a heart attack. Let's bring it down to 300. Like, nobody would do that. And so
Right.
I think, like with all things, you just got to be reasonable, right? Don't be too low. You probably don't need to be at like 6,000. That's probably not good for you either. But there is a good normal, maybe on the upper end of normal, so you get a little bit more performance benefit that we kind of aim for. And everybody's going to be a little bit different in that.
So to that aspect, you had mentioned, you know, there's two different levels of improving your testosterone. One, you had mentioned from a medical standpoint, hey, you're really too low, and you've increased your risk of all of these things. So let's bring you up to something. And then, you know, where we live is more of this healthy lifestyle, optimized, you know, energy levels and things like that, where we try to bring you all the way up to the, you know, the 900 to 1100
Yeah.
range. Do you do the same thing with your practice, or are you more hey, let's just keep you in, I don't want to say let's just keep you, but is it more of a, let's avoid these risks and get you to a good level, or let's optimize your, some of the things you want to do so you can go hiking in the alpine and do some alpine
No,
hiking?
I definitely follow the philosophy that the patient's symptoms are more important than the numbers. To me, the numbers are useful at the bounds, you know, at the upper and lower extreme. Like, I don't want to be below X, and I probably don't want to be above Y. Anything in there, I care more about how the guy's feeling, right? And so I
Yep.
certainly don't have any kind of artificial like, oh, 500's enough. And the guy's like, well, I'm so tired. I'm like, yeah, 500's enough. I don't do that, right? I know some people do, very conservative people do. I think that you can keep going to the point where the guy is feeling better. And as long as you're not going crazy, and as long as you're not getting significant like side effects like hair loss, acne, you know, prostate stuff, you know, or whatever, extreme polycythemia, having to donate blood like every 2 weeks or something like that. And so, you know, the problem with testosterone in general is that the normal range is like 300 to 1,000, which somehow implies that 301 is the same as 999, which it obviously is not. And because none of us have like a baseline from when we were 18, really, right? I don't know. Maybe your 800 is my 400, right? Like you're some really muscular, athletic, you know, military, like all whatever. He probably needs a higher testosterone than I do to feel the same way. And so I definitely think that there is, you can have the symptoms. When you make a guideline, you have to have a cutoff number, but all of us would agree that just because your T is 299 doesn't suddenly make you have low T. And then when it's 301, you're like perfectly normal, right? I will certainly
Yeah.
treat men up to 300, 400, 500, probably not like above 600. I just don't think that the likelihood that you're going to get a lot of benefit is there unless you're purely talking about the anabolic potential of testosterone, in which the tissue saturation is probably very, very high. And so you can keep going. I mostly care about mitigating risk as I see it. But then I just want the patients to like feel better, right? And I would say most patients, not everyone, most patients probably feel the best at that very upper end of that normal range. So 800, 900, 1,000, but does anybody really need to be above like 14, 1,500? Probably not. And that's where your risks start to go up, especially with the polycythemia. So.
That's really
Yeah, it's funny you say that. I just did a marketing video yesterday, and I said exactly just the same thing you said, right? That 301, how can 301 be the same as 1,000?
Yeah.
Even though they're both in the normal range, it's all about how that guy's
And
feeling
what's even more
at a
funny
certain
is
point.
that,
So
many people's, like, let's say they use a regular, like a lab, like a Quest or LabCorp, right? And the range for like reference ranges for labs is based on like the fifth percentile number for the last like 10,000 lab samples that they drew, right? So if you actually look at the range today versus 10 years ago versus 20 years ago, the range is lower to still be called normal
wow,
today because the average testosterone level in the country is lower. And so we're just moving the goalpost to say, well, I guess you're still okay, even though absolute numbers wise, it has decreased over time. So that's why I think it's still more useful to use something that's just like set as an absolute number. We should not adjust our expectations for what is normal based on the fact that like everybody's less healthy,
everybody's
Yeah.
low, right? Doesn't make any
Yeah.
sense. Amina, you were about to say
Yeah,
something. I'm
can you
sorry.
speak a little bit about in clomiphene and how that kind of does boost the levels, but the symptoms necessarily don't go away, and how that's correlated to free T, total T, and the impact of your overall, optimization of testosterone?
Sure, yes. So as a fertility doctor, I do use a lot of, shall we say, Clomid, aka or Clomiphene. Clomid, well, I guess that's the name brand. So clomiphene citrate is a combination of zuclomiphene and Enclomiphene. Zuclomiphene is a little bit longer acting and a little bit more like estrogen promoting. Enclomiphene is the more androgen promoting aspect. And so Enclomiphene alone has been studied as like, can we use this to increase endogenous testosterone production, right? Because both of them have the same mechanism of action. By blocking the brain's perception of estrogen, the LH and FSH levels in the brain increase, which send a stronger signal to your testicles to make more testosterone through the LH and more sperm through the FSH. So in men with low T and low sperm count, we're trying to have a kid, we give them clomiphene, right? That for that one, I just mostly use clomiphene because I don't really think that Enclomiphene and the clomiphene matter so much. And sometimes we also use anastrozole to promote. Anastrozole blocks testosterone to estrogen conversion through aromatase, and so you create more intratesticular and intra-body testosterone. That's truly boosting your internal production. Now, the challenge is that usually, I would say 90% of the time you give a patient clomiphene or Enclomiphene, their numbers get better, and probably 40 to 50% of the time they actually feel better. And so there's this big discordance between like the numbers going up and people feeling better with these endogenous boosting agents. To be fair, no one has really ever definitively determined why that is. Um, there are many hypotheses. One hypothesis is that estrogen is also important in terms of libido and a lot of the sort of feeling of the testosterone benefit. And so by blocking the brain's perception of the estrogen levels, even though peripherally in your body the testosterone level is higher, your brain doesn't feel it as much because it's not sensing the estrogen component. That's one theory. I will say personally, I used to believe that theory, and I believe it less now. I personally think that there is just some sort of fundamental difference between endogenously produced testosterone and exogenously administered testosterone because I have 20 or so patients in whom they had low T, right? Let's say 250. I gave them Clomid for 3 months. Their Ts on average were like 500, 600. But like these guys didn't feel better, right? The guys that felt better, I just said, okay, keep taking the Clomid. The guys that didn't feel better, I then gave them once daily Kysotrex, which is oral testosterone undecanoate. It's normally supposed to be done twice daily, but I just gave it to them once a day. Then when I checked their peak T levels, their testosterone is 1,000. It was like 1045 was the average, so 1,000. And they like 18 of the 20 felt better, right? Now, if the estrogen blocking theory was correct, their estrogen receptors are still blocked. all I've done is add more exogenous testosterone, but these guys felt better. And so to me, that implies that there is just some fundamental difference that I cannot explain to you exactly what, between endogenously increased testosterone and exogenously administered testosterone. Now, one other interesting thing there is that normally your body regulates the amount of free testosterone through the production of sex hormone binding globulin, or SHBG. Some people just have genetically high SHBG. Drinking a lot, having liver dysfunction worsens that. Taking Clomid usually increases SHBG. Either it's doing it independently, or it's like the body saying, this is my own testosterone, and now I have more of it, so I have to increase the production of SHBG to like regulate it, because I don't actually want there to be that much. But if you override that system by giving an external testosterone, maybe that's why the patients feel better, because you don't have this increase in SHBG. And then even more so with the oral testosterone Kysotrex, that it's the one form of testosterone that's actually been shown in clinical trials to actually decrease the production of SHBG. And so in those patients that I have, right, there's 20 patients, their T was low, they got Clomid, their T went up, but their SHBG also went up. So their free T went up some, but not that much. When I added the Kysotrex, their total T went up a lot, right? So 250, 500, 1,000. But actually their SHBG went down because of the effect of the Kysotrex. So not only was their testosterone 1,000, but they also had way more free testosterone because of the lowering of the SHBG. And again, that may also be an explanation for why they suddenly felt better. And so, these things are all nuances. For most people, if you just increase the total testosterone, regardless of the SHBG level, you will also increase the free testosterone. Free testosterone is probably the more important of the two when it comes to actual symptomatic benefit. The challenge is that the variability in the calculation is very high, and most places do not use a direct equilibrium dialysis measurement of the free testosterone. It's mostly calculated. And so because of that variability, that's why the guideline statements are all written to direct measured total testosterone, because it's more reproducible. But in reality, it's probably the free testosterone that matters more when it comes to what actually is happening in terms of the metabolic piece of it.
Yeah, we definitely see some patients that have, and we had one the other day, and he just called back and was happy to hear that his free T was low because his total T was in the 800s, and he was just like,
He doesn't feel it.
I don't
It
feel
has high
good.
SHBG.
And
That's a guy that I would consider giving
yeah.
him like the oral testosterone that basically suppresses the SHBG. And I've used that actually in combination. So I have some patients who are on injections. Their total T number is like 1,000, but they have so much SHBG that their free T is still low. And I'm like, well, I could just keep raising the total T to like 1,500, but then they get all this crazy polycythemia and they get side effects. And so I'm like, what if I combine testosterone formulation? So you're taking both injections and oral. So you don't have to take quite as much injection, but then you're using the oral to suppress the SHBG to get more free T, but not drive the total T up so high, because most of the side effects happen when you have really high total testosterone levels.
Does it matter what time of day you're tested for your total testosterone?
It does, and especially it does the younger you are. So the diurnal circadian rhythm of natural testosterone, this is only true for people that are not taking testosterone, right? So your natural testosterone levels are always higher in the morning, and they go down throughout the day. Now the guidelines are written almost to like dissuade you from prescribing testosterone, right? Because they're like, you got to check it in the morning. And my argument has always been like, well, what if the guy comes in and he's like complaining of being tired at 5 o'clock in the afternoon? Does his morning level of 325 really, exclude him from being a qualified candidate for testosterone if his afternoon testosterone is like 150? No, and so that variability does even out with age. And so if you look at like younger men, there's a big variability between the morning and the evening. And the older you get, the more flat it becomes. And probably at like age 60 to 70, it's pretty much equal. That's for natural. Any guy who's taking testosterone replacement therapy, of course, the timing of the labs is based on the pharmacokinetics of the type of testosterone that they're taking. So for an injection patient, if you check them the day after the injection versus a week later, obviously that's going to be different. For an oral testosterone patient, it's a little bit even more tight because it's secreted over a period of like 8 to 10 hours. So you have to check it in this 3 to 5 hour time window to get what the peak excretion is. That's why for most of the oral patients, I tell them to take it at lunchtime, because the most common complaint I treat is afternoon tiredness. And so by taking it at lunch, you get the peak T level between 3 and 5 p.m., lasting until about 8 to 9 p.m., but not overnight when you naturally make your own testosterone, and not in the morning when you have your natural daily high of testosterone. And so they can still preserve some of that while getting the sort of afternoon booster shot from this type of tea. When you're doing injections, you're basically on T 24/7, so it doesn't really matter as much. But obviously the numbers are going to be very different depending on when you check it.
So in your practice, and what do you see as the biggest side effects or any reservations for prescribing testosterone for a
testosterone in general? Sorry, I didn't hear that part. But yeah, I mean, in general, for all forms of testosterone, they all have the same warning on blood pressure. So there's that one, right? If you're a super bad high blood pressure guy, well, first of all, you should probably go get that controlled. But that's one thing. Secondary conversion of testosterone occurs with prolonged, sustained, super physiological levels of total testosterone. The way that I talk about it is like the body has so much T, it doesn't know what to do with it. So it's like, let's convert it to some other stuff to try and get rid of it, So you convert it to what? DHT. DHT acts on the prostate and on hair loss. And so that's a side effect. Estrogen through aromatase. And so you can get this high estrogen level, and you can block that with, anastrozole, letrozole, those kinds of medications. But those are probably the two big secondary metabolites. And then elevated red blood cell count. That would be the three things. And then that's true with all versions of tea. It's just at different percentages, right? So you see that more with injections than pellets, relatively speaking, because they create really high levels that last for a while. You see it less with gels and oral because they don't create as high of a peak for as long. As with any oral product, the most common side effect is going to be GI upset. That's just always true. Topical, skin irritation, injection site irritation, or just fear of the needle. Those are all pretty germane things. But so, as a class-wide thing, those are the other ones.
What I'm hearing you say is that the benefits certainly outweigh the symptoms of low T. And if managed and monitored properly, it mitigates a lot of that anyway, right?
Absolutely. I mean, the importance of having good, normal, or even just the better end of normal levels of testosterone from a functional aspect, a health aspect, a psychological aspect, a mental functioning aspect, a metabolic aspect far outweigh the relatively few downsides there are, especially if you take testosterone under the supervision of, licensed practitioners who can kind of wash these things, right? We're not talking about back alley gym bro tea. This is under supervision, right? With making sure that all the safety factors are limited. Those safety factors are actually quite low, but the benefits are massive, especially the lower your testosterone is at baseline.
So what are some of the red flags that people should watch out for when choosing a hormone specialist to kind of look after their care?
That's a good question. My answer to that question is probably going to be very different than some, being a fellowship trained urologist in a big urology medical practice, So I think that, to me, the same red flags there would apply as with anything in medicine, which is if it looks too good to be true, if it smells too good to be true, then it probably is too good to be true, right? And unfortunately, there's going to be a lot of people peddling snake oil, especially in this business. So you want people with a track record. You want people that seem to know what they're doing, and you don't want to fall for what just seems almost too much, right? The fundamental goal here is the promotion of overall health. And that is the North Star that everybody should be sort of thinking about at all times. In this space, you're going to have a lot of sort of unscrupulous people. But fortunately, I think over the last few years, as more research has been done and people have gotten sort of more used to this and gotten better, it's actually improved a little bit compared to maybe 10 years ago when it was sort of more the Wild West. Yeah, I think looking for that track record that this is something that they do is helpful.
Very good. Well, I appreciate your time. I guess the couple last questions I would have would be, just, maybe we touched on this already, but for any of the guys listening out there that may think they have an issue, what's your general message to get them to go in, see somebody, to your point, see somebody that has a track record, and get checked out, kind of what's your message to
Yeah,
them?
I think, even if it sounds trite, like the fundamental message is just like, it's like Nike slogan, like just do it, right? And understanding the hesitation that a lot of people have. I think that, it's probably the most helpful thing that you can do, not just for your, whatever it is you're thinking about, but for your future, for your kids, for your family, for your health. If those things don't appeal to you, then for your sexual health, all of that. And I do think that, this is where organizations like Game Day are very helpful, because in the conventional medical world, there's just not as much access to like urology, primary care, some of that stuff as we need as a society. And so I think one of the nice things about your model is your availability, right? Like you guys do much better than we do at like getting people in who just want to come in. For us, sometimes you got to wait like a month or two, and that is unfortunate as a factor of the fact that there's just so few of us. But a lot of times if you call and you're like, oh, you got to wait like a month or two, they're just not going to come in, right? And so I think that having that availability and expertise that you guys have is really helpful to sort of expand the reach of this in a way that people like me, maybe struggle with doing.
Yeah, and I think there's a collaboration that's there that I don't think the Game Days of the world and urologists of the world have quite yet figured out, but I think it's available, right? We have customers that come in that are low and they want to use their insurance, and it's like, well, we don't take insurance, and I think we all would love to have, hey, go see Dr. Sun, or go see, you're in Dallas, but go see this urologist who can help you out, and vice
Yeah,
versa, right?
absolutely.
You may have
Absolutely.
somebody that is a little higher than what you normally treat, and they're like, well, I want to do a little, I want to do something else. I want to try something else, or I want to try peptides. I don't know, something
Yeah,
that you
no,
guys don't
100%.
offer,
I think
and
that
you
you're
have a
absolutely right.
place.
I think
Yeah,
we probably do like 5% of the possibility in terms of collaboration. I very much value my local collaboration with, a lot of similar clinics. Basically, if they're on treatment and they need elevated PSA clearance, or they have urinary dysfunction, they send them to me. If they wanted to like have sort of close to home convenient management of their testosterone and not have to wait in my line and like do all this stuff, then I send them to Game Days or whatnot. And I think having that sort of mutually beneficial relationship is not only good for us, but also much better for the patients than any type of adversarial relationship, right?
very true, very true. Amina, did you have any more
No,
questions before I
this
wrap
has
up?
been amazing. I mean, just
Yeah.
the way you've explained things have really kind of been easy to understand. And, I really appreciate that. Thank you for your time.
Yeah, absolutely. It's fun.
My head's still buzzing
So
with all
the last
the
question, go
the
ahead.
things that you mentioned. So this has been great.
Yeah, and to that point, you know, I don't know if this is self promoting or not, but I am very happy that a lot of the things that you were saying, resonate. Not only just like Amina was saying, just it's great information, but it's great to hear that we're all kind of talking
Yeah,
the same language, right? When it comes to these customers and what we're telling them, so that they're not getting really anything different. They just, different practice, different whatever, but we're all kind of saying the same thing. So I'm really encouraged and happy about that. And thank you very much for your time. And the last question I kind of leave everybody with is just, and maybe you could think about this for your customer or even for yourself, but in tough times when things are kind of difficult or seem a little bit challenging, what do you kind of say to yourself, or maybe what do you say to a customer, to kind of keep that prime time mindset going, and not overwhelm yourself?
mm, yeah. Wow, that's a very deep question. I admit I don't know. I have my own personal answer, but that's not applicable to most people. And so it probably wouldn't be what I talk to my customers about or my patients about. For me, it stems from my family, and I'm Chinese descent, but I was born in Connecticut. My parents came here to study, and just like, the sort of journey and stuff that they went through to achieve what they did to give me the tools to achieve what I have is something that I'm continuously grateful for. And, I just try to keep it in perspective, right? Like, there's always your own little world and like what you're thinking of, and sometimes the problems seem like really big or like significant, but when you keep it in perspective of like not just the grand arc of human history, but where you came from and where you're at, I think there's always positivity to be seen there. So that's what keeps me going personally.
Very nice. Very nice. I love that answer. How can those out there listening or anybody looking to find a urologist in Dallas, how can they find you?
So our
Socials
practice is called Urology Partners of North Texas, or UPNT. The UP is definitely purposeful as a urology clinic. We have 7 locations in DFW, Arlington, Fort Worth, a bunch of different areas. Our website is pretty easy. It's www.upnt, urologypartnersofnorthtexas.com. You can find us there. We have a lot of helpful information. You can make appointments with us if necessary. That's probably the easiest way.
All right. Well, thank you very much. Thank you to my co-host Amena for being a part of this. You enlightened us with all of your great questions and your presence. So thank you very much, Amena, for being here.
Thanks.
And for anyone tuning in, thank you very much for being a part of this episode. Don't forget to subscribe, leave a review, share this episode with someone who's building something of their own. And as always, thank you very much and have a great day.
Take care.
Thank you.